Hello, my name is Dr. Roger Henderson and I'm a GP, and I also co-host the GPnotebook study groups. Welcome to this GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Spotify, Apple Podcasts and Google Podcasts. So do please follow us to receive notifications about new episodes, and if you like what you hear, do please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups, and you can find me on there too, at Roger the Doctor. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about our upcoming study group meetings, which run throughout the year. Now, in this episode, we're going to be discussing testicular torsion. And this was the topic specifically requested by one of our GP listeners who wanted a quick refresher of this condition, which is so important not to miss in practice. Testicular torsion is a medical emergency, and so it's vital that us as GPs make an early diagnosis in order to prevent serious complications such as necrosis and loss of a testicle. Now, there are two types called intravaginal and extravaginal. Now, the most common type is intravaginal torsion, and this occurs because of an abnormally high attachment of the tunica vaginalis to the spermatic cord. And that then allows rotation of the testicle. And if both attachments of the tunica vaginalis occur superior to the testicle, we get the deformity that is called a bell clapper deformity. And that occurs in about 10% of all men. That's bilateral in about a third of cases, and it is the most common predisposing factor why torsion occurs. In contrast, extravaginal torsion is rare. And this occurs during the perinatal period, before the testis is fixed in the scrotum as the testicle descends and twists around the spermatic cord. And so if it does occur, it appears more commonly in neonates. In about 4 to 8% of cases, trauma may also be a trigger for torsion to occur, although the exact mechanism of this isn't clear. And in a very small number of cases, a long mesorchium may be the cause. And this is a dense band of connective tissue that attaches the efferent ductules of the epididymis to the posterolateral wall of the testis. And if that's excessively long, that allows the testicles to twist. But essentially, the bell clapper deformity is probably the leading reason why torsion occurs. And all of us must have a low threshold for suspecting testicular torsion in any young boy or man who presents with an acute painful scrotal swelling, sometimes with associated low abdominal pain. Now, although it can occur at any age, we have to say that it doesn't usually affect older men. It's got a peak incidence between the ages of 13 and 16 and is most commonly seen in those aged between 12 and 18. In young men under the age of 25, the annual incidence of torsion has been estimated at around 1 in 4,000, and it is possible for torsion to occur and then resolve spontaneously. And in those cases, there's a history of episodes of severe self-limiting scrotal pain and swelling that then settles over time. But in any young male presenting with abdominal pain, I would suggest we must always consider a diagnosis of torsion. So the typical presenting history that we're all familiar with is of sudden, severe pain in one testis, often linked to physical activity or exercise, and it may also be associated with nausea and vomiting. If you elevate the scrotum to try and take the pressure off the testicles, the pain does not ease, and that's an important point to make. And there's often low abdominal pain, which varies from mild to severe. Unfortunately, a history suggesting torsion with the pain easing gradually does not mean this is a good sign, because it doesn't mean it's just spontaneous resolution. Unfortunately, it can also mean that testicular necrosis is actively occurring. One of the first questions you must ask any patient that you're considering a diagnosis of torsion on is how long the pain's been present, because patients presenting with symptoms lasting less than 6 hours have a much greater likelihood of testicular viability occurring. Unfortunately, the chances of achieving testicular salvage consistently fall as the symptom duration increases. And if you're getting symptoms extending over 24 hours before treatment occurs, then there's consistently poor testicular salvage results, unfortunately. As a general aside, if you've got a patient who's also got a raised temperature, dysuria, and penile discharge, these are not symptoms we'd typically associate with torsion, and in fact are much more suggestive of something like inflammation or infection. Now, if you see a patient with a high suspicion of torsion but normal clinical findings, this should not preclude further investigation. So, when examining a patient that you're considering may have torsion, there's often reddening of the scrotal skin with severe tenderness on palpation of the affected testicle. The testes may actually have a transverse lie or be in a high riding position compared to the unaffected testes. And lifting the testes up over the symphysis may increase the pain. Now, something we should always remember is to check for the absence of the cremasteric reflex. As you might remember, this is the L1, L2 spinal nerve linked reflex, and you can stroke or pinch the inner thigh to do this. And this should normally cause ipsilateral testicular rise, but this may be absent in the cases of torsion. Elevation of the testes, as I say, does not result in any pain relief, and this is known as a negative Crane's sign. One of the ways I tend to evaluate the possible diagnosis of testicular torsion is to use the TWIST score. This is a clinical risk score which we can use to support the assessment of a young person with testicular pain. And it's also been validated for the diagnosis of testicular torsion in adults. Now, this is a 7-point score generated from 5 parameters. And these 5 parameters are testicular swelling, a hard testes, a high riding testes, nausea or vomiting, and an absent cremasteric reflex. And these are scored up to a maximum of 7 points collectively. And the scores are categorized as either low risk, a score of 0 to 2, intermediate risk, 3 to 4, and high risk, which is 5 to 7. And the scores have a sensitivity of 98% in low risk patients and a specificity of 97% in high-risk patients, although it is important to say the score of 4 or less does not completely exclude testicular torsion. And I think I'd come back to a key point here, is that all cases of acute testicular pain must be viewed as being due to torsion until proved otherwise. If you find that torsion is present, an immediate referral must be made to the emergency urology or surgical team. Now, if the history and your physical examination do suggest testicular torsion, then immediate surgical exploration should take precedence over any diagnostic tests. So the point here is that investigations should not delay treatment. Treatment comes first. And one of the reasons for this is that all imaging studies, such as ultrasound in this case, can have a false negative rate. And so it's far more preferable to have a negative surgical exploration rather than a missed torsion diagnosis with all the subsequent complications that go with that. Now, ultrasound assessment, as we know, is non-invasive and rapid and can easily determine the presence of testicular torsion if there's time to do this. And the National Health Service England Getting It Right First Time pathway suggests that ultrasound should be indicated in scenarios such as newborns with a suspected torsion, if there's a strong suspicion of an alternative diagnosis which would significantly change the planned management, As an adjunct to diagnosis of torsion for children and young men, if the pain is present for less than 48 hours and it doesn't result in a significant delay to treatment, or if the pain has been present for more than 48 hours. However, UK guidelines from the Royal College of Surgeons actually say that in patients with a history and physical examination that's suggestive of torsion, imaging studies should not be performed, as they may delay treatment and therefore prolong the ischemic time. It can also be possible to manually reduce a testicular torsion. And if this can occur, it's highly suggestive of the diagnosis, and this can be attempted if surgery isn't available within 6 hours or while preparations for surgery are being made. But it is only a temporizing measure, it is not a treatment. And the technique involves rotating the affected testicle as if you're opening a book. That's why it's actually called the open book method, but that does require adequate sedation and pain relief. And blood flow seen on Doppler is then the objective measure of successful detorsion. But as I say, this is only a temporizing measure, so even if this occurs, bilateral orchidopexy is still required as an urgent procedure rather than an elective one. And the two most important determinants of early salvage rate of the testes are the time between the onset of the symptoms and detorsion and the degree of cord twisting. Now, as we know, surgical treatment is the definitive treatment of testicular torsion, and up to 40% of cases of testicular torsion result in an orchiectomy, and the risk of losing a testicle is actually much higher in younger males. There's some evidence that orchiectomy is more likely to preserve the function and fertility of the ipsilateral testes, but if the testis is found to be viable, then orchidopexy is usually performed to prevent any recurrence. Now, because the risk of torsion occurring in the unaffected testicle is high, the contralateral one should undergo orchidopexy irrespective of whether the affected testis is removed or conserved. Now, the extent and duration of torsion significantly impact both the immediate salvage rate and late testicular atrophy. Testicular salvage rates can be up to 100% with surgical correction within 6 hours of the onset of testicular torsion, but this can plummet to as low as 10% by 24 hours. And the absence of a testis can have a significant psychological effect, and so it's usual to implant a prosthesis following an orchiectomy. And usually this is now a saline-filled silicone implant, which can improve cosmetic appearance and psychological well-being. And it's typically delayed for 6 months to let any post-operative inflammation subside. So, thank you all for listening, and I do hope you found that quick overview of testicular torsion helpful. Please do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email support@GPnotebook.com if you have any questions, comments or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and download free shortcuts to help improve the lives of our patients in primary care. But as always, until the next time, goodbye.